I've been asked to talk about adaptive CRT, and before I launch straight into it, I want to give a little bit of an update about conventional CRT, and then we'll move on to adaptive CRT. Why are we here? Why are we all come to Seville? It is a fantastically sunny place, as Dr. Williams showed, but heart failure is the main reason we're here. And we have 26 million cases of heart failure globally that we know of. Per year, we get about 6 million new cases. And unfortunately, every 4 years, we lose about half of them. That's the problem that we have with heart failure. So where is conventional CRT? I think we'd all agree, especially the implanting physicians will agree, that conventional CRT is a fantastic treatment. It reduces heart failure mortality by 40% on top of optimal medical therapy. It reduces hospitalization by 52%. Great, fantastic, job done. What's the problem with CRT? Well, the problem with traditional CRT is it fixes on having fixed intervals for atrial ventricular conduction and ventricular ventricular conduction. And we often set these up at rest, lying down in the lab, and never change them. And most of the time, they come in, they're set at the factory settings that come out of the box. For a while, we've been looking at echo-based optimization of CRT. And we know from all the trials that looked, AV and VV intervals are usually the targets for optimization. Unfortunately, following the Prospect trial, echo-based optimization has been proven to have relatively little evidence base and is time-consuming and costs. All the trials going back historically across CRT have stuck at around a 67, so 2/3 response rate, going from the Miracle trial in 2002 all the way to Prospect in 2007. Why do people not respond to CRT? And we alluded to this earlier. There is a number of drivers for why people don't respond. But far and away, the most common driver is suboptimal AV timing. And I want to focus on that later on in this talk. So the two things I think we need to discuss when we're saying we want to improve response rates. I want to talk about LV pacing with RV fusion, which is what adaptive CRT is, and I want to talk about AV timing. So let's talk about LV pacing first. In CRT, is it important to pace the LV or BiV? Which one's the more important? Well, if you go back to the original hemodynamic data that Dr. Cass published in Circulation in '99, he did a lovely trial where he looked at pressure volume loops and compared them to intrinsic left bundle. So the green line here shows left bundle branch block pressure volume loops, and the red line shows an RV apically paced pressure volume loop. And I think we'd all agree they're near enough identical. You look at RV septal pacing. There's a big vogue for septal pacing because apparently improves hemodynamics and makes us all feel better. Pressure volume loops are identical for RV septal pacing to left bundle branch block and RV apical pacing. Then they looked at biventricular pacing. So this is simultaneous LV and RV pacing and found, yes, your end systolic volume reduces. Your end diastolic volume reduces. Your stroke work and your stroke volume increase. And the last bit they looked at was LV free wall pacing. So this is LV on its own with no RV pacing. And they found that they got a significantly increased response. So you got less of a end stroke volume, reduction in end diastolic volume, more of a stroke work, and more of a stroke volume. So if we go back to that data, we'd say that the original hemodynamic data suggests that LV pacing was certainly equivalent, if not better, than BiV pacing. So why did all the trials look at BiV pacing? Why did we not look at LV pacing? Now, I'm old enough to remember the initial days of CRT, and one of the reasons I suspect we went for BiV pacing in all the trials was that at that time the systems were fairly simple. You could only pace having Y connectors and 2 electrodes. Simultaneous pacing was the only option. We were worried about LV lead stability because there were only single-shaped leads, they were unipolar, so we wanted the idea of having the backup of an RV lead. We also didn't think that RV pacing was that bad for you in the year 2000. But now in modern pacing, CRT remains the only place that we aim for 100% RV pacing. Everything else we've moved away from that. So what's the trial evidence for LV pacing since Dr. Cass's original paper? Well, there have been about 5 or 6 trials which I've referenced at the bottom, and they've shown that intrinsic RV activation, so fusion with the intrinsic RV, is more physiological, that you get better hemodynamics with LV pre-excitation if the heart rates are below 100 beats per minute, and by not using the RV lead to stimulate, you save device energy. The rough calculation from Medronic on sort of projected data is about a year better battery life by not pacing on the RV. It did find that bi-V pacing is more preferential if you have AV delay. So if you have prolonged AV, extending the AV interval until you get RV intrinsic pacing causes presystolic mitral regurgitation and changes the LV filling pattern and is not beneficial. So if you have prolonged AV, bi-V pacing is still better. Let's talk about the improving in AV conduction, and we'll come back and tie all of this together in adaptive CRT. Why is AV conduction important in CRT? And this is a lovely slide from Dr. Yu, which shows how CRT improves things. I think we all accept that CRT improves things by focusing on 3 things: intraventricular synchrony, AV synchrony, and interventricular synchrony. And I'm going to split it up by each one. So intraventricular synchrony increases your RV stroke volume and increases your diastolic filling. AV synchrony reduces the amount of MR, reduces the LA pressure, improves diastolic filling, and reduces your end diastolic volume. And interventricular synchrony increases your cardiac output and reduces your LV end systolic volume. Those latter 2 cause reverse remodeling. But the take-home message from this slide for me is how important AV synchrony is. It's the cornerstone of CRT therapy. So let's talk about adaptive CRT with the whole point of this talk. And I'm sorry it's taken 15 slides to get to here. What are the main goals for adaptive CRT? Well, the main goals are to achieve LV-only pacing in patients with normal AV conduction. We want to achieve dynamic AV conduction to simulate simulate normal AV function. What do we mean by that? We mean by that most of us have an AV interval that changes depending on what exercise we're doing, whether we're resting, whether we're running, so forth. If you set it at one fixed interval and never change it, that is not physiological. And we want to optimize the AV and VV intervals to improve CRT response. So the way adaptive CRT does this is a very clever bit of programming. It measures the AV interval every minute, all the time. So every single minute, it will prolong the AV delay out to let intrinsic conduction come in and find out what that person's AV interval is. And every 16 hours, it'll prolong the AV delay out and measure the P wave duration and the QRS duration. And the advantage of getting that data is it can then optimize the settings on the CRT to manage that patient's current AV delay and QRS width. So what does it do? So if you have a patient with normal AV delay, what it will do is it will recognize what the PR interval is, and it will ensure that it paces just the LV prior to the intrinsic QRS coming in. And it will time it about 70% of the AV interval before it paces. And this allows it to pace in the LV and let intrinsic conduction go down to the RV and cause fusion between the LV and the RV. Let's say that person now goes for a bit of a run. They increase their physical activity. What happens now? Or when they increase their physical activity, hopefully because their AV function is normal, their AV interval will shorten. So then, because it again measures it every single minute, and the next time it measures it, it recognizes that the AV interval has shrunk. So now it brings the LV pacing forward and makes sure that it gets LV pacing on its own again. What happens if 3 years down the line, either due to medication or due to something else, their AV conduction deteriorates? Again, because it's measuring it on a minutely basis, it will recognize that the AV interval has gone out, recognize that that isn't good, and it will go back, it'll switch over to bi-V pacing, which we know is more beneficial in this patient group. And it will use adaptive LV pacing when 3 criteria are met. When there's a regular rhythm, when the heart rate is below 100, and when there's normal AV conduction. What does adaptive LV pacing do? As we said, it leverages intrinsic RV conduction by pre-pacing the LV to synchronize with the intrinsic RV activation. It reduces the amount of pacing in the RV by about 44%, and that leads to an increased battery life of about 6 to 12 months on the battery. We'll talk about the clinical response in a second. If they go into BiV pacing, this isn't still the same BiV pacing you get with your older devices. This is adaptive BiV pacing. So here, it's going to optimize the AV and the VV delays on the based on changes in the patient's activity and conduction status. It'll do continuous assessments of the AV and the QRS duration and benefit and change the settings to maximize those two. And hopefully by doing that, it'll maximize ventricular filling and ejection. Does it work? Well, it's a fantastic bit of software programming. Meeting the guy who came up with it is inspirational, but does it actually do anything? Well, the trial that we've had so far to this is a 522 patient prospective, multi-center, randomized, double-blinded study. So a good study design with a decent number of patients. And it compares adaptive CRT to what is the current gold standard, which is echo-based optimization. And this was published in Heart Rhythm in 2012. And they compared it to echo-based optimization at 1 and 6 months. The first thing they had to prove was that they were as good as echo optimization. So this is a non-inferiority graph, but it shows that adaptive CRT picked up the people that responded at around the same level as echo did. Certainly no better, no worse. Then they looked at the patients that got adaptive LV pacing, and they compared the group that got adaptive LV pacing less than 50% of the time to getting it more than 50% of the time, and found that if you got more adaptive LV pacing, you had a significantly lower death rate and a rate of hospitalization. Now, the only rider I would put on this slide is, by definition, if you are getting very little LV pacing in the adaptive LV arm, it suggests that you're either getting atrial arrhythmias or have AV conduction problems. That's why you're not getting the LV pacing. So you could argue that this patient group that's getting the higher death rate and hospitalization are a more comorbid group, and you're not comparing like for like. I think that's a criticism you could give this slide. So then we looked at patients who had normal LV conduction. So let's look at like-for-like patients. So these are all patients with normal AV conduction, and the dark green arm has got adaptive LV on, and the blue arm are control, are the echo group. And what they showed was that the response rates in the control arm was about 69%. And if you go back to that slide we had at the start of what response rates historically are, that fits in very well with the historical controls of between 67 and 69%. But in the adaptive LV arm, we can get response rates to up to 81%. Now that goes beyond anything we've had in any of the multi-center trials looking at CRT. And again, if you look at just the normal AV group, so you are comparing like-for-like patients, you do see that over a 12-month follow-up, there is a reduction in death and hospitalization with an odds ratio of 0.52. This is significant. The other thing that came out of this, which was a little bit more of a surprise, was that adaptive CRT compared to echo-based CRT reduces the amount of AF you get. And again, this did meet significance. This, I have to admit, was a little bit more of a surprise for some of us. And if you compare it to the historical trials, adaptive CRT seems to give you around a 12% higher response rate than the historical trials gave us. Now, as we said at the start, we have a finite resource for dealing with these patients, so anything that we can do to increase their response rates and get more value for the money we've spent is beneficial. The last slide I want to show is one from a recent presentation at HRS, which I think is a very nice slide. So here they've looked at 80 patients with normal conduction and QRS durations of 120 to 150. And most implanters will tell you that this is the group that don't respond as well as the people with very broad QRSs. And they've looked at the group with adaptive CRT and they looked at the control group. And the first thing I would highlight is here, that this is what we historically feel, that this group only has about a 50% response rate, and the echo group shows that. But in the adaptive group, you're getting an almost 79% response rate. Now, that kind of response rate is what we'd see in the group with a QRS duration of a greater than 150. So in relatively narrow complexes, you can achieve a higher response rate than you would normally get. So what do I conclude from all of that? Well, I think adaptive CRT can certainly be considered as an option to help maximize CRT response. I think we have good data that it's a viable alternative to echo optimization, and for any of us that do echo optimization, we're very thankful to Medronic for giving us something that's a hell of a lot simpler. And there's emerging evidence of improved response and reduced AF. Now, this is very promising data, but it does need more long-term evaluation and more trials to prove it. Thank you.